Welcome to this video on cardiopulmonary bypass. We will cover the basic structure, including introduction, initiation, maintenance, management challenges, weaning, and finally, termination. Cardiopulmonary bypass is a method of extracorporeal circulation that temporarily performs the functions of the heart and lungs. Its primary goal is to create a motionless, bloodless field for surgery while maintaining essential oxygenation and perfusion. The essential goals of CPB are myocardial and patient protection. This is achieved by maintaining a delicate balance between the patient's metabolic demands and oxygen supply, particularly when cardiac function is interrupted. A CPB circuit consists of several key components: the venous reservoir, the arterial pump, the oxygenator for gas exchange, a heat exchanger for temperature regulation, and an arterial line filter to remove emboli. Arterial pumps generally come in two types: roller pumps, which are positive displacement devices, and centrifugal pumps, which use kinetic vortex flow. Each has distinct advantages and risks regarding pressure control and blood trauma. The oxygenator functions as an artificial lung, using hollow fibers to facilitate gas exchange. Integrated with it is the heat exchanger, which allows for the induction of hypothermia to lower metabolic demand during surgery. Before bypass begins, proper preparation is vital. This includes confirming deep anesthesia and muscle relaxation to prevent movement and shivering, while using EEG monitoring to ensure the patient remains unaware. Anticoagulation is a mandatory requirement before cannulation. Heparin is the standard drug used to prevent massive thrombosis when blood comes into contact with the surfaces of the extracorporeal circuit. Effective anticoagulation is monitored via the activated clotting time, or ACT. It must be checked 3 to 5 minutes after heparin is administered, with a target threshold typically above 400 seconds before initiating bypass. Arterial cannulation is typically performed via the ascending aorta. During this process, systolic blood pressure is carefully managed between 90 and 110 millimeters of mercury to minimize the risk of aortic dissection. Venous cannulation is required to divert blood to the pump oxygenator. Depending on the procedure, surgeons may use a single or two-stage cannula or bicaval cannulation, particularly when the right heart needs to be opened. Vents are placed to decompress the heart and prevent distension, while cardioplegia cannulas are used to deliver the solution required to safely arrest cardiac activity during the procedure. Every team must follow a strict pre-bypass checklist, confirming that all components are connected, valves are set, drugs are administered, and the patient's ACT is within the required range before proceeding. As bypass begins, venous clamps are released and pump flow is gradually increased. Hemodynamic changes follow, with right-sided pressures dropping and the arterial waveform transitioning to a non-pulsatile state. Finally, we enter the maintenance phase, where the focus remains on continuous monitoring of the patient's systemic perfusion and the ongoing performance of the CPB circuit. Once on bypass, hemodynamic management is critical. Initiation often leads to systemic hypotension due to the hemodilution effect, lowering blood viscosity. Practitioners aim for a mean arterial pressure of 50 to 90 millimeters of mercury. To maintain proper perfusion, target flows are usually set between 2.2 and 2.5 liters per minute per square meter. Alpha agonists like phenylephrine are frequently used to manage temporary hypotension and maintain stability. pH management is another vital consideration. Two primary strategies are used: alpha-stat, which manages blood gases regardless of core temperature, and pH-stat, which adjusts measurements to the patient's actual hypothermic temperature. Alpha-stat is the standard for adult procedures as it preserves natural cerebral autoregulation. Conversely, pH-stat is preferred in pediatrics or deep hypothermic arrest, as it promotes cerebral vasodilation for more uniform cooling. Temperature management relies on the circuit's heat exchanger. Cooling reduces metabolic oxygen demand significantly. Rewarming at the end must be done gradually, with blood temperatures kept under 37.5 degrees to protect the brain. Myocardial protection centers on arresting the heart in diastole. This drastically reduces myocardial oxygen consumption. When combined with localized hypothermia, oxygen demand can be reduced by up to 97%. Cardioplegic solutions are generally blood or crystalloid-based. They are classified by their mechanism of action, with most using potassium to induce arrest through depolarization, or intracellular formulas that use sodium depletion. Common solutions include St. Thomas's Hospital solution, the Del Nido formula, popular for its single-dose efficacy, and custodial, which is frequently used for its ability to support longer periods of cardiac arrest. Inhalational anesthetics can also be delivered directly through the oxygenator's sweep gas line. This ensures a consistent depth of anesthesia while potentially offering organ protection benefits against reperfusion injury. Adequacy of perfusion is continuously monitored. Clinicians track mixed venous oxygen saturation, aim for target hematocrit levels, and use cerebral oximetry to monitor for regional perfusion issues. Transesophageal echocardiography is an indispensable tool during bypass. It allows for the early detection of ventricular distension and provides real-time guidance during weaning and de-airing procedures. Hemodilution is an unavoidable side effect of circuit priming. Hematocrit is typically managed between 21 and 25%. Maintaining these levels is vital to mitigate risks associated with anemia during the bypass run. Despite all precautions, perfusion emergencies can occur. These include mechanical pump failures, massive air embolism, or procedural errors like reverse cannulation. Rapid identification and response are crucial for patient survival. Reverse cannulation is a life-threatening error where lines are swapped. This leads to systemic venous engorgement and arterial hypotension. The pump must be stopped immediately if this is suspected. Detection of air embolism is supported by modern circuit alarms, such as bubble detectors and reservoir-level sensors. Visual confirmation via TEE and monitoring with transcranial Doppler are key clinical safeguards. Massive air embolism is a catastrophic event if air enters the arterial line. Immediate response involves stopping the bypass, clamping all lines, and placing the patient in a steep Trendelenburg position. Clinical management for air embolism includes retrograde cerebral perfusion to flush air out of the cerebral circulation via the aorta. Pregnancy requires special consideration during CPB. The procedure alters uterine blood flow and vascular resistance due to high catecholamine release, which can impact placental perfusion. Perfusion management in pregnant patients includes maintaining a mean arterial pressure of at least 65 millimeters of mercury to sustain fetal oxygen delivery. Profound hypothermia should be avoided to prevent fetal distress. Pediatric bypass presents unique challenges, primarily due to the large priming volume relative to the child's small blood volume, leading to significant hemodilution. Children have higher metabolic demands, necessitating higher flow rates and specialized temperature management. Their exaggerated inflammatory response often requires modified ultrafiltration. Deep hypothermic circulatory arrest is utilized for complex aortic arch repairs. The patient is cooled to 15 to 22 degrees Celsius, and blood is drained to provide a temporary window of safe global ischemia. To protect the brain during circulatory arrest, clinicians often use selective antegrade or retrograde cerebral perfusion as a vital neuroprotective strategy. The weaning process begins with rewarming the patient to a core temperature of 36 to 37 degrees Celsius. It also requires meticulous de-airing of the heart chambers using vents. Clinicians often use the CVP mnemonic to prepare for separation, checking cold status, contractility, cell counts, calcium, and coagulation, as well as ventilation, volume, pressure, and heart rate. If a patient fails to wean, the team must assess for causes like myocardial stunning or incomplete revascularization, often escalating to mechanical support like IABP or ECM. Heparin reversal with protamine sulfate is essential. It is dosed based on heparin levels, and administrators must be alert for rare but severe anaphylactic reactions. During decannulation, venous lines are removed first. Surgical and medical hemostasis must be confirmed, as final chest closure can sometimes cause hemodynamic instability, requiring fluid or inotrope support. Thank you for watching this overview of the principles and practices of cardiopulmonary bypass. We hope this information provides a clear understanding of this critical surgical procedure.